What do you tell your clients when they ask about their risk of prolapse or if a prolapse will be worse after a subsequent birth? In today's podcast, I speak with Taryn Hallam, a physiotherapist and founder of Women's Health Training Associates in Australia, about pelvic organ prolapse, the potential causes and risk factors, as well as what role pelvic health therapists can play. Hello, friends. This is Lynn Schulte, and you are listening to the Birth Healing Summit podcast. We are here for meaningful conversations that will transform the way you work with pregnant and postpartum clients. Whether it is a new perspective, tool, or technique, you'll be able to implement it into your practice today. I invite you to sit back, listen with an open mind, and grab the golden nugget today's guest has to offer. Now let's get started. Hello, everybody. Welcome to this episode. Boy, do I have a treat for you today. I am so excited to introduce you to Taryn Hallam. Hallam, did I say that correctly?
Yes, you did. Perfect. Thank you.
Taryn was correcting me before we hit the record button. And, you know, when someone tells you to say it this way and you've said it another way, and then you like, wait, which way did I say it? Is that...
It's absolutely fine. No
All right.
problem at all.
Thank you. So Taryn is a physiotherapist down in Australia, and she used to be very active in the clinic, and she has now turned her efforts and energies into educating through the Women's Health Training Associates company that you founded, correct?
Yeah, I did. About, oh
Yes.
gosh, it was over a decade ago now. So
Oh my
time
gosh.
flies.
That's
Yeah.
awesome, right? And she is amazing at going through the research and helping to bring the research to us clinicians to help guide us in our practice. So welcome to the podcast, Taryn. Thanks so much for being here.
Oh, thank you so much for having me. It's very kind. And yeah, the research is it's an interesting thing. It's always lovely to share what the research is telling us. And, you know, physios are always so keen to know what's going on. And yeah, I really have a privileged role. I love what I do. And so it's lovely to be here.
And I so appreciate that you have the mind for and the analysis of the research to be able to dissect it and bring us the important points to help guide us in our clinical practice. And that is a
Yeah.
gift and a skill.
Well, no, I think just a nerd. I think I'm a self-professed stats nerd.
I'm going to disagree with that, Taryn, because it does take a unique mind to be able to read and the statistics and to really pull out, like you said, sometimes they can really kind of twist things, or if you don't know how to really dive into it to get the nuances of the research, that's why my brain doesn't work in that way. And
That's
so
hard. They are really tricky. And the papers get written in ways that it can be really confusing to say, what does this really mean as a clinician? They're tough. Yeah.
Well, and that's why I so appreciate your gift and your skill in being able to do that, because I don't have that. That is not my skill
Well,
and my gift.
thank you.
And so I honor that and I know that about myself. And so I'll read a research and go, okay, great. What did that tell me?
Yeah.
You
Yeah.
know?
Well,
So
hopefully we can make that simpler. Yeah.
awesome. So
Hopefully.
today we're going to be talking about POPs, so pelvic organ prolapse.
Mhm.
And what does the research tell us about whether someone is at a higher incident to develop POP, or especially in pregnancy and labor? So in
Yeah.
labor, how do we guide, or how do we know with our clients if someone is going to develop POPs or not?
Okay. So this is such a multifactorial phenomenon. It has so many components to it. So probably what I need to do is start by just focusing on one area so we can sort of get our head around this, because, you know, we see it in the clinic, don't we? You have patients that, it sounds terrible, but you almost expect them to have prolapse. They're the person who had the really difficult labor, obstructed in second stage, 4.9 kilo baby, ended up with high rotational forceps, and you go, oh yeah, this person's going to have prolapse. And you've got the person you expect it, and then it's there. And then you get these outliers. You know, you get the person who has that really traumatic birth and their pelvic floor is absolutely fine. And then you get the woman who actually had what you'd almost say is the textbook birth, the birth where, you know, maybe first baby, 10-hour first stage, hour second stage, no obstruction, birth's fine, minimal tearing, and she's got this terrible prolapse. And And what is happening there? So there's ones we can explain from birth, and there's ones that just seem to confuse us. And I think that was the first insight that researchers started to say there is more to this. I have this quote that I often bring from a paper that I loved, and it was about a decade ago now, but Dernier and colleagues, and they published in the IUJ, and they were looking at predictive factors. And basically what they were saying is that there's this increasing body of evidence that pelvic floor dysfunction can't just be explained by childbearing. We want to put all the birth-related factors. It's because of the birth, it's because of, and we're not saying it's not related to that, but it's not only related to that. And that probably its birth is on top of an intrinsic weakness, that some people have an intrinsic weakness, and then when you expose them to birth, it's going to show it up. Other people don't have that intrinsic weakness and they can handle the birth. So yes, the birth is a triggering event, but it had to happen on top of an intrinsic weakness. That has led us to research in all the areas of pelvic floor dysfunctions, whether it's urinary incontinence, fecal incontinence, prolapse, is who are the people who have an intrinsic weakness, and why do they have an intrinsic weakness from that they just always have? So that is our first bit, is where the research headed that way. And probably the earliest research we had on this is that said to researchers, let's start looking at family history, because if this is intrinsic, were you born with this? So it's natural to say, let's go to family history. And it's been shown. We have a study right back in about 1999. It was Chiafarino, they published, and they were saying if you have a mother with prolapse, you're 3 times more likely to have prolapse. If you have a sister, you're 2.5 times more likely. Norton came out quite a few years later, Norton and colleagues, and they were like 2013, 2014, somewhere there. And they were saying if you have a mother with prolapse, you're close to 6 times more likely to get prolapse than if you don't have a mother with prolapse.
Wow.
So you have all these studies, and obviously they're all individual studies. They all come out with slightly different numbers because they sample different people with different genetic backgrounds and things like that. But we got to a systematic review only a couple of years ago, and Samimi in 2021 looked at all of it and came to sort of a middle ground and said, on average, how much does family play a role? And they were sort of 2.5 to 3 times more likely to have prolapse if you have a family member with prolapse than if you don't. And so this is one of the things I say to clinicians. If someone's sitting with you and saying, what, am I at risk? Am I at risk? Are we actually saying to them, is there anybody in your family with prolapse? Do you have a mother, a sister, a grandmother who has prolapse? Because if they do, is there an intrinsic weakness that has been passed on and that you are more at risk? And it doesn't mean they definitely will, but there's a starting point sort of there.
Taryn, where my mind goes with that is, are we looking at this familial, relationship as habits and patterns that are being passed on, or is it truly genetic tissue that creates the problem?
Okay. So that's really, really fascinating, because Bushbaum did this amazing study. It was way back in sort of 2006, and what they did was they got, I think it was 200 women, but don't quote me on that. I'm pretty sure it was 100 in each group. They specifically chose these women because they were pairs of sisters. So there was 100 pairs of sisters, giving you 200 women. They were average age about 60, and the 100 of them were nulliparous, had never had a baby, and 100. So they managed to find 100 pairs of sisters where one had had a baby and one hadn't. Okay.
Okay.
When they looked at that, what they actually showed was that in 2/3 of the sister pairs, all their anatomical landmarks by POPQ, whether you do AA, BA, CD, AP, BP, were within a centimetre of each other. And that was even though one had had a birth and one hadn't. Does that, yeah?
Wow.
Which means that there is absolutely, there's 2 things you can say by that. We take the birth bit out and we say, okay, now is that genetics that mean they're within that? Or is it that they grew up in a life where they developed the same patterns, whether it was exercise, whether it was dietary and constipation? So now we're like, okay, there's something going on there that you can have that did and didn't have a baby. They're from the same family and they're within a centimeter of each other for all their points. Now that was 2/3 of them. So obviously there was a third that didn't match and there was differences from birth, but 2/3 of them were really close. But then you put that together with a study by Alcalay, and they looked at something really interesting because lifestyle factors tend to cause prolapse over a really long period of time. If you're constipated, it's rare that you'll get someone who's constipated and at 35, one day they get prolapse. We know that when you look at someone who's 70 and they've got a lifelong of constipation, they get prolapse, but it's this slow over a long period of time. But we know, as opposed to that, birth can be an event where you didn't have it, now you have it. Like, it's very definitive. And that's what makes the Alcalay study in 2015 really fascinating. So there's mild prolapse, there's severe prolapse. And we like to sort of take out the mild prolapse because it's so mild. It's a bit of movement, barely symptomatic. You'd almost put it in the realm of normal. So what they did was they looked at whether you have prolapse severe enough to need surgery. And they compared women who were so severe at under 45 years that they needed surgery versus women who didn't get that severe till more than 55 years. The chance that you have a family member who actually has prolapse is 5 times more likely if you get severe enough prolapse to need surgery under 45 than over 55, which makes us say, okay, there is probably this multifactorial thing. Genetics is going to make, and family history is going to make a huge link to getting early severe prolapse. But if you wait till everyone's 70, there are so many other factors that are going to come in with lifestyle and diet and, and constipation and respiratory factors that you'll start watering down how dramatic that is by the time you're 70, which is really interesting as clinicians because, a lot of the studies are, what is your risk of prolapse at some point in life? But our women who are pregnant are coming to us saying, what's the chance I'm going to have prolapse at 34 straight after this birth? And what it seems to be is that is where your genetics and the birth becomes a really big factor. But it doesn't mean that you won't long-term have other risk factors that will come into play, if that makes sense.
Yeah.
It's sort of lots of bits together. Does that,
Yeah, that's very interesting. So genetics and that family history is one of the biggest things that we need to be asking our clients if they're concerned about prolapse.
Yeah. The thing about genetics that's really fascinating about genetics, though, is that I've sort of mentioned having a mother or a sister with prolapse. The question is whether you've asked the paternal family history as well. And people are going to say, asking your dad or your grandfather, and you go, where is the link there? Well, where this comes from is that, so Lynn and colleagues talk about in their paper looking at risks of prolapse, and they say what we're looking at is genetic mutations that lead to changes in collagen metabolism. And if you have a genetic mutation, that means your collagen metabolism is altered, you'll get weakened fascia. And that weakened fascia is more likely to tear, damage in the birth, okay? Now, interesting, Alan Brady and colleagues in 2011, they have actually isolated at least 6 different single nucleotide polymorphisms, like genetic mutations that they know are there. They can find them and they can now look in people. If we all had the money and the governments or whoever could all fund it, you could actually have a genetic test now and they could look for the genetic markers for risk of prolapse. We know them, they're there, and they've actually found them. And if you have them, and they've shown that they pass both through the maternal and the paternal side in a dominant fashion. So if your father's mother, so your grandmother on your father's side, has prolapse, it can pass through your father to you. Sure. If it's your mother, if it's your sister, so it can pass both, and it's in a dominant fashion. So it will actually take the lead role if you have one from one side and not the other. And so having it on one side will be enough. Whereas if it was recessive, you'd need it on both sides. Okay.
Okay.
So whereas because it's dominant, you only need one of the genes for it to take the role in there, which is a bit unfortunate, but makes sense of why prolapse is so common. There. But then you go, okay, what if you don't know? I mean, your father might not know if his mother had prolapse. That's probably unlikely.
Yeah, it's not like they go around talking about that
About
to
that.
a son in particular,
Yes.
right?
So yeah, but interestingly, if a male carries these genes, they still have the fascial difference, which means they're more prone to hernia. So if you have a father or an uncle who has a hernia, which is basically just a prolapse at, at the groin, like,
Inguinal
or
area.
anywhere else, inguinal hernia or something like that, it's just the fascia giving way like it does in a pelvic organ prolapse. That means that that gene is probably passing and you are higher risk. So clinically, saying to a woman, do you have a mother, a sister, a grandmother who has had prolapse? At what age if they had surgery, did they need it? Oh, my mother had to have prolapse surgery at 44, as opposed to, well, yeah, my grandmother had prolapse surgery, but she was 82 and she had a long-term respiratory problem and she was a smoker and she was this and that and, those things.
Yeah.
Oh, yeah, and my father and my uncle have both had hernias, and you go, oh, okay, there's a strong genetic link here.
Yeah. I was curious when you said their dad or uncle, because I was curious if an aunt having a prolapse is just as important for us to ask versus
Yeah. So,
a sister versus mom.
yeah.
It doesn't
So
matter.
if you had, because I think the thing is that say you, you have a mother who's had 2 cesarean sections. Cesareans are very protective against prolapse, so she doesn't have it. But her sister had a vaginal birth and got a severe prolapse. You go, okay, somewhere in this family tree. Now, it's not guaranteed that your mother got the gene, because if your grandmother had it and it's dominant, she may have had like a capital D, little d, and she may have passed the capital D to your aunt and the little d to your sister,
Right.
to your mother, sorry. And
Yeah.
then so it may not be, but it's somewhere in the family line. So it's possible that it passed through. Whereas if your mother, so it gets less, obviously, the more you distance away, that the way that it passes, but it would still be relevant there.
Absolutely. Yeah.
Yeah.
And so I'm just curious, any thoughts or any research on if a person does have a high genetic predominance for prolapse?
Yeah.
Any guidance that we should give our clients? Does the research say anything to help them avoid a prolapse during labor specifically?
So this is still really in its infancy, this part of the research. And so I do want to say, I'm going to give some early things, but like any research, it's not until we get it repeated over and over that we know it's not just a chance finding that this happens. So now we've got the issue of, you could be a genetic risk, but you could have the breeziest birth ever and you be absolutely fine. You could be, but you're a higher risk. That's when we look at multifactorial analysis. So we say, okay, so we know there's genetic risk. Now we know that for people at genetic risk, forceps are your next biggest risk factor for prolapse. Now, the question then is, why forceps? So the why of forceps is forceps seems to increase the chance that you will have a levator revulsion. And if you have a levator revulsion, then the levator hiatus is larger and therefore it's got this big gap under the organs and doesn't give as much support, and therefore you get the prolapse. So the next thing would be, how do you avoid forceps? Well, that's a bit difficult because forceps could be done because of obstructed labor, the baby's just not descending, or it could be done because the baby's suddenly its heart rate's dropping to 50 beats per minute and the cord is tangled and they've got to get the baby out now. So you can't predict all forceps, okay?
Right.
But there are some forceps that are related to obstructed labor that we have more research on there. So what we now the research starts to be leaning towards women who have a really small levator hiatus, okay, at start. So women who are really, really high tone prior to the birth are more likely to obstruct. Women who, when they push down, like they're trying to pass a bowel motion, instead of relaxing their pelvic floor, they co-contract their pelvic floor. That seems to link to having a longer labor, obstructed labor. So if we see things like really high tone, non-relaxing pelvic floors that co-contract, that would be something I would say that is putting you at increased risk of obstructed labor. If you have an obstructed labor, you're more likely to have forceps. If you're more likely to have forceps, then you're more likely to have, like, so let's manage that. That's sort of, it's this extrapolation down to reduce the risk of that's probably one area that we can look at.
And Taryn, I'd love to know if there's any research. So if a person does have a prolapse and now they're in a subsequent pregnancy, will the prolapse get worse? I get that question all the time with my clients. So do we have any research on that?
This is where I am going to have to give you an answer that I sometimes have to give, and I hate having to give this answer. If you'd said to me 4 months ago, do we have any research on this? I would have said no, because we actually had no research that was actually following up people at 6 months after a second birth. Okay. So we do know studies where we've looked at women who've had 1, 2, 3, and 4 births at 75 years of age. And if you've had 4 vaginal births, there's a higher incidence of prolapse than if you've had 1, but that's at 75. Does that, yeah? The other research that we have is that the change to the levator hiatus is predominantly with the first birth. So if you look at the jump in the levator hiatus, one thing we do know is virtually no one gets a new avulsion after a second birth. So if you're going to have an avulsion, it's on the first birth. It's not on the second or the third birth. It happens on the first birth. If you go through the first birth without an avulsion, unless something really weird happened, like the baby's arm was on its head and it was coming with a face presentation, elbow first and whatever. But outside of that, you don't get avulsions on second. So what we know is that the pelvic floor itself, it's a little bit, it can be a little bit pessimistic, but the damage is done on the first birth. People often say to me, if you have a woman come to see you and her uterus is 1 centimeter outside the vagina, like the cervix is sitting 1 centimeter out, she's got a bilateral avulsion, she has no pelvic floor contraction or whatever, should she have a Caesar? Why? Like, what's that going to help? The damage is done. The horse is bolted. Like, you're going to subject this woman to an abdominal operation when the damage is already there.
But I think so many people are afraid to make it even worse with the subsequent pregnancy.
What, it'll go from +1 to +2? Like, you have to manage it anyway. So you will have to manage, like, it's not a level of prolapse that you can't manage. So we're going to be having to manage this, whether it's pessary, whether it's surgery, whether it's there's going to be a management anyway. The people I worry about are the people whose cervix is sitting at -4 centimeters inside the vagina. We know that uterine prolapse has become symptomatic for most women around that 4 centimeter mark. So if she's at -4, sitting at 4 centimeters inside and asymptomatic, she changes 0.5 centimeter, she's going to become symptomatic. She'll go from asymptomatic to symptomatic. That's the person I worry about. The person who got through a first birth with their cervix sitting 8 centimeters in, unlikely it's going to get worse with another birth. The person who's gone from 8 centimeters into 4, even if she moves 0.5 centimeter, she's on the cusp, and we go from fine to symptomatic. But at +2, even if you go from +2 to +3, she was symptomatic before, she's symptomatic now.
Yeah.
What's the thing?
What about
Yeah, sorry. Yep.
I was going to ask about rectocele. I've had a client recently in my clinic who has a grade, it was a 2 or 3. It was near the opening. So
Mm,
I'm trying to remember
yeah,
what it was, but she was so concerned about making it worse in that next
worse.
delivery. Is
Yeah.
there any research on?
Okay, so this is rectocele is a bit of my rectocele is really a bit of my little pet topic at the moment.
Yeah.
I talk a lot about rectoceles, and the reason that I talk about rectoceles is because I think physical therapists historically have grouped all prolapse together, and they group cystoceles, uterine prolapse, and rectocele as prolapse. And I think we need to shift culturally that rectoceles are different. They are completely different
I treat them
to
differently
cystoceles
for sure.
and uterine. They are completely different because the thing about cystoceles and uterine prolapse is if you think about how a cystocele drops, it drops from anterior heading backwards. It goes backwards. Uterine prolapse drops straight down. When you
Yeah.
think about how the pelvic floor contracts, it lifts and goes forward. So it goes in the opposite direction. So if your bladder's dropping back and the pelvic floor goes forward, it's going to counteract that. If the uterus is dropping down and the pelvic floor lifts up, it counteracts that. Rectoceles drop forward and the pelvic floor pulls forward. And
Yeah.
so there's no way the pelvic floor is going to push a rectocele backwards when it pulls
Right.
forwards. And we actually have research that if you split the pelvic floor muscle training research into cystocele and uterine versus rectocele,
Yeah.
we actually don't have evidence that pelvic floor muscle training improves rectoceles.
I totally
We
agree
don't,
with what I find in my clinic
it
too.
doesn't, it does
Yeah.
improve it because it's pulling it forward and that's the way it's going. Now,
Yeah.
interestingly, that sounds negative, but now I'll give you the positive spin on that. The
Okay.
positive spin is most pelvic floor muscle training research has all 3 compartments in it, which means that when the rectoceles don't get better, it dilutes the result. And it actually makes the result look less good because they don't get any improvement. When you
Yeah.
look at studies that take the rectoceles out, the pelvic floor muscle training research on bladder and uterus is much stronger than what it normally looks like
That makes
because of the
sense.
dilution effect of those things.
Yeah.
So with rectoceles, the good news though is, and to be honest, I will say to you, I believe there's a place for all types of management. There's a place for very first line conservative pelvic floor muscle training lifestyle advice. There is a place for pessaries and there is a place for surgery. Okay, there is a place for all of them. Rectoceles, the good news about them is that a straight native tissue posterior colporrhaphy, posterior repair is a very low risk operation and it has one of the highest success rates of all the prolapse surgeries. So the thing is that if there's any prolapse you want to have a surgery for, it's a rectocele because you can have the most basic one, it works really well, and it has a good longevity and it fixes, which means that if you've already got the rectocele and you're probably not going to fix with pelvic floor muscle training anyway, you might symptomatically be able to manage them through splinting for defecation if they've got obstructed defecation. And I'm not, that's a separate thing of whether you can manage the symptoms as opposed to fix it. If this woman knows that she is going to want that rectocele fixed at some point, the surgery is not less effective if you have a slightly worse rectocele. It doesn't change. So the thing is, why would you subject yourself? You know, at some point, you're probably going to have a posterior colporrhaphy. That's one surgery. Why would you subject yourself to an open laparotomy if you're going to need that anyway?
Got it.
Again, really different to a cystocele that's mild. Anterior colporrhaphies are the Achilles heel of surgery. They have the highest failure rates. They recur. You need to have it again. They're not a good surgery. They struggle to hold. So if you have a mild cystocele and you're hoping pelvic floor muscle training will get it better, we know that the worse a cystocele gets, the harder it is for pelvic floor muscle training to work. We could be sitting with something that at the moment we can conservatively manage you and avoid a surgery that has a really high failure rate. But if you have another birth and it gets worse, then the pelvic floor muscle training might not work And then you need the surgery, and the surgery is not great. And
Yeah.
it's sort of, so they're very different in their approach, I think.
Yeah, absolutely. Oh, wow. That is so interesting. My concern for that rectocele, and I love that thought of my concern is if baby's head is like dragging that rectal tissue forward as it's coming
Yeah.
out, it's going to make it worse. But as you're saying, that surgery, whether it's a 2 or a 3, is going to be the same and the results are the same.
That
And
are the same. So she might get worse. Now, the thing that I didn't get to before that I didn't say is, so in preparation for the research update this year, when I put together a research update, my first step has to be to scour the research and just download every article that's potential. I can't even remember off the top of my head the author because I haven't read the paper yet, but I have a paper downloaded this year that's looking at the change in prolapse from a first to a second birth. And it's the first paper ever been done on this, but I haven't read it yet. So
okay.
I've downloaded it. It's come out in the last couple of months, and I can't tell you what it says yet, but I
Okay.
will in a few months.
Okay. That's
So
awesome.
unfortunately, that's the downside of my role is because I'm downloading papers every week. Sometimes people go, is there any research? And I go, well,
Kind of.
now, yes, but let me get to reading it. I haven't read
Yeah.
it yet.
Yeah.
So
Oh
yeah.
my gosh. Oh, that's great. Well, super. So we could all search for that though and find that paper
Yeah,
and read it.
it's
Yes.
there. I'm sorry, I can't off the top of my
Whatever.
head. I know
Yeah.
that the author. It's in one of my folders for things to
Okay.
read over the next couple of months. So and then
Okay.
I'll know it more.
Yeah.
But I have downloaded that. It's like, okay, we have a paper now. Let's see what this is saying.
I am very intrigued
In
by
first, because
that.
we've never looked at that. We've never looked
Yeah.
at immediately after the second birth, how much worse and what happens over a year. I think from my memory, they have followed them over a year, but I don't
Great.
quote me on that.
Yeah.
Yeah, to
Yeah.
see.
Cool.
So to have some data, but it will be the start of looking at
Yeah.
that.
Yeah.
Yeah.
Oh, Taryn, this has been amazing. And I just want to highlight to everybody what Taryn's talking about is that every year she does a massive research review and then
Yeah.
presents it to practitioners. I believe you're doing it in November and March of next year because there's so
Yeah.
much. And the
Yeah.
topic is pregnancy postpartum this year.
Yeah. So
And so,
the November focus will be pregnancy postpartum, but not pelvic floor. So it'll be DRAM, exercise in pregnancy, back pain in pregnancy. In March, it will be the pelvic floor related to pregnancy and postpartum. So I've split them based on the bits that are pelvic floor and the bits that aren't pelvic floor. And we'll look at all the research for the last year to 2 years on that, what's come
awesome.
out.
Yeah.
Yeah.
And I want to put a little plug out there, everybody. Taryn has also done a Birth Healing Summit interview with me for this year's Birth Healing Summit, where we go dive into OASIS and the research of how do we determine if someone's going to get worse or if they're going to develop one. And oh my goodness, it's amazing what you share in that interview. So please, it's
That
a
one's a bit easier. The research is more solid on that.
yeah.
Prolapse, we're still developing. We're still getting there. It's like a bit of this and a bit of that. Whereas they've done a lot more on the fecal incontinence and OAC research. There's a lot more there.
Awesome. And you did a beautiful job in sharing that with us in that interview. So thank you for
Thank
that.
you.
And another little plug, your gift for the summit is a discount on the research review. So
Yeah.
that I just want to let everybody kind of plant that seed so that can percolate in them. And hopefully you'll join us for the Birth Healing Summit and listen to Taryn's interview there and then get that gift. And then you can hear more about all this amazing research that she is reviewing and helping us to understand how it impacts our work with our clients in the clinic. So just absolutely
I think
fabulous.
everyone's going to be excited about stats. That's my goal in life. Everyone's going to be excited about odds ratios and confidence intervals and clinical significance. That's my thing. Is everyone's going to love
Okay,
stats.
the clinical significance, yes, you got me on that. That other stuff, I'm not so sure, Taryn.
Yeah.
Uh,
Yeah.
that's awesome. Thank you, thank you, thank you for sharing what you did with us today. And I think the biggest thing I'm taking away from this is really, the more we can help our mamas, like try to get baby into best position possible, really release that levator ani muscle and the hiatus and get that to relax, help our mamas learn how to push effectively so that they don't have that
Yeah.
paradoxical contraction. All that can help them avoid
Abs- yeah.
certain issues. So
Yeah.
that, I know we're already doing that work. We just got to do it better and more
Yeah.
so that we can help our clients hopefully
Yeah, have the
avoid.
best outcome. Pelvic floor, I think for a long time was always focused on wait for till you have the problem and then we try and manage it. And I think we're just starting to see, I would say in every other area of health, it's prevention of osteoporosis, it's prevention of cardiovascular disease. And it's like pelvic floor needs to move to a proactive, how do we, maximize? And I think we're just starting to see some research looking at this from a proactive approach to
Yeah,
maximizing outcomes for women, which is really exciting.
that is. And I believe social media is going to be a huge plus for us in helping to make that turn, because I'm
Mm,
just been amazed at how much just all the PTs and all the information getting out into the world, people are now aware that they have a pelvic floor.
yeah. The one thing I probably would like to just to throw in with this is it's always tricky with this is when we talk about family history risk and genetic risk, the risk of talking about that though is that we actually make people paranoid. If my mother has a prolapse, I will have a prolapse. Remember that increased risk is just increased. The reality is, whilst 30–40% of women can have mild anatomical movement without symptoms that some people would say is prolapse, but it's non-significant, only about 6% of women actually get significant clinical prolapse to the point where they're symptomatic every day, significant movement. So when I say the risk doubles, it goes from 6% to 12%. It still means that 85% won't. And I think the problem with stats is we hear things like doubled, tripled, and we automatically think everyone. Doubled is significant if you go from 40% to 80%, but 6% to 12%, we have to keep in context. Still, most of them won't. But are you a higher risk than someone else? So should we put more effort into you because you're higher risk? But we don't want women to hear these stats. So we've got to be really careful with social media that when we say things like double and triple, women don't know how to interpret that. And so, as clinicians, we can understand what that means, but women will easily catastrophize that. And so that's really careful how we present stats with social media. Social media is great, but we've got
Yeah.
to be careful as well to not
Yeah.
scare women.
Yes, thank you so much. We do talk about that more in the Birth Healing Summit interview as
Mm,
well. So thank you for
yeah.
that caution as
Yeah.
practitioners to really be mindful of what we're putting out there so that we're not scaring people into um that fear response, which we know tightens
Mm.
up the pelvic floor, makes
Goes up the
everything
pelvic floor, and it's all a problem again.
right? So, oh my gosh, this has been so awesome, Taryn. You are incredible. Thank you so much for your
No,
gift.
it's been lovely to be here. Like I said, I'll always talk stats. I'll talk stats and data, and yeah, that's no
It's
problem.
it's important. It's important for us to really realize the significance of that. And I also would just want to say, our skew, our population of people that we see are those that have problems and issues.
Yeah.
So we're skewed
We
towards.
are skewed, so skewed. And I, we were having this chat before, weren't we? And we were talking about, if you're an obstetrician or if you're a midwife or if you're a physio, you get different people. And how do we not skew? I mean, it's sort of like I used to say, so I did 10 years working clinically in the hospital setting, and then I did 10 years working in private clinic. But when I was in the hospital setting, we had this joke because I was in a big women's hospital in Sydney, so the Royal Hospital for Women Sydney. And so we had a big pelvic health physio staff there. But we also, I think we had like a pregnancy chair, like people who sat on that chair fell pregnant. We were all falling pregnant all the time. So we were pelvic floor physios working in a maternity hospital, and we were all falling pregnant ourselves. And the problem with that is when you're always seeing pelvic floor, you start, how do you have a positive approach into birth when you're seeing this all day, every day? And it was that element that we had to sometimes say, okay, you need to be on back pain for a while because you're now 35 weeks and you need to get positive about your birth coming up. Let's not give you these every day because we need to let your head, and we all had that experience of we are skewed and then we start to think we're all going to have a problem when we're not.
Well,
What do
the
we do?
statistic you shared in your summit interview was that 70% of pregnant or 70% of people who give birth don't have pelvic floor
Don't have
dysfunction.
anything. So if you add up OAC, you add up avulsion, you add up all the different sort of traumas. Now it gets to about 30%, something like that. It gets to about that 30% level. And the authors published it because they were trying to get OBGYNs to be more aware that it's higher than you think. The purpose of the article was to say it's not 5%, it's up near 30%. As a physical therapist, what we take away is, wow, we feel like it's everybody. But
Sure.
70% of women are absolutely fine because we're never seeing them. Yeah. So it's how do you view that stat? Yeah.
Absolutely. Yeah. So recognize that we are biased. And I tell my clients that too, I'm like, they ask, oh, should I do the surgery? And I'm like, well, you really don't want to ask me because I only see the people that don't do well with the surgeries,
all
right?
the surgeries that are great, we never see.
Right.
And we see the ones where they went wrong. And we're all biased. All of us are biased.
Right.
Yeah.
Oh, well, the research does help support us in our guiding our clients. And that's what I'm so grateful for, the work that you do and help us to understand that research better so that we can guide our clients better. And I want to just thank you for sharing what you did today and thank everybody else for listening in and taking this information to your clients to better support them in their decisions. And I really encourage everyone to please join us this year for the Birth Healing Summit and learn more about what Taryn shares with us there. It's incredible, you guys. It's information you must know. So I hope you will all join us there. Thank you, Taryn. Thanks everybody for listening in.
Thanks for having me again. Thanks.
Yes, you're so welcome. Here's to smoother births and faster recoveries, everybody. Take care. Bye-bye.
Bye.
Today's podcast was brought to you by the Institute for Birth Healing. To discover more, visit instituteforbirthhealing.com. To claim $50 off of any online course, use coupon code PODCAST50 at checkout. Till next time, I'm Lynn Schulte, founder of the Institute for Birth Healing.